This is the Healthcare Education Transformation Podcast, a podcast brought to you by two physical therapists devoted to helping physical therapists and other healthcare providers become better educators to patients, students, the community, and each other by interviewing prominent and passionate people within the realms of healthcare and education. The Healthcare Education Transformation Podcast is intended literally for educational and entertainment purposes only. No clinical decision-making should be based on only one source, and therefore this podcast should not be used as personal medical advice. While care has been taken to ensure accuracy, occasionally mistakes and factual errors can be present, as we are only human. This is our journey on the road to becoming better educators, so get ready with your pen and paper as class is about to begin.
Hello all, and welcome to another episode of the Healthcare Education Transformation Podcast. I'm your host, F. Scott Fiel, and as always, I'm joined by my co-host, Brandon Pone. We're continuing to branch out in the world of healthcare education in an effort to help all healthcare practitioners learn about what goes on in the educational programs of other disciplines, in an attempt to help us better understand what our roles are in the spectrum of patient care. Tonight, we have the pleasure of having nurse practitioner Heather Hart on the show. Heather received her BSN from Belmont University in 2009 and began her nursing career at Skyline Medical Center on the cardiology step-down floor. Then she advanced to a charge nurse position where she developed a love for critical care nursing. She accepted a position at the Vanderbilt Surgical ICU in 2012, where she also worked as a charge nurse and later took on the role of clinical staff leader. She has chaired several committees at Vanderbilt, including the SICU Performance Improvement Committee, the SICU Quality Subcommittee, and Nurse Champion Subcommittee for the Organ Donation Advisory Council at Vanderbilt. During her tenure in the SICU, she was awarded the Rosamund Gabrielson VUMC Staff Nurse of the Year in May 2016. Heather has led various published projects, including interprofessional implementation of the CPOT in surgical and medical intensive care units for the Society of Critical Care Medicine. Heather recently completed the AGACNP Program at the University of Alabama at Birmingham and joined the Level 1 Trauma Center at Vanderbilt as a new member of the ICU team of nurse practitioners just this month. Heather, thank you so much for coming on our show tonight. I realize we kept your bio relatively brief, but is there anything we left out or anything else that you'd like our audience to know about you?
I feel like it wasn't brief. It was very kind, and I think that kind of sums it up in a nutshell.
Awesome. Well, just reading and kind of hearing all that you've done, you've definitely seemed like you've done a lot over the course of your career, and that's awesome. And, for our listeners, perhaps, do you mind kind of telling us a little bit about your academic journey and how it led to where you're at today?
Sure. So it's interesting. I think I'm one of a lot of people entering the healthcare world now that started in different worlds, had different careers prior to getting into healthcare. I initially got my BA in French and a BS in international economics with the intention of working in the wine industry. I graduated in 2006, also from Belmont with that. And I worked in Nashville in sales and kind of just getting my feet wet in the business industry here, and kind of in a very strange turn of events ended up reevaluating career choices. And I began taking some prerequisites for nursing school at Belmont. They had a fast track bachelor's to BSN in nursing that was a 16-month program. I got into it, and it was basically nursing courses all the way through for 16 months. Because I had a previous bachelor's degree, they counted some of my core work towards the nursing degree, and I was able to graduate with a BSN after 16 months of an intensive program. So my educational journey is, I feel like I've been in school forever. But I think, as someone put it in a leadership class I took a couple of years ago, I think that my generation, it's up for debate which generation I really belong to. I'm kind of on the cusp there. It's just that my generation is going to be one of the first who are not going to bring home as much financially as our parents did. And a lot of that has to do with a shift in, I want to say values, but it's not to speak negatively about the values of our parents. I think the generation of my parents was focused on providing for a family, having a family, building kind of the classic American vision of a family. And hopefully you get to retire at a young age and then do what you want. And I think that the generation that's coming into industry, all industries right now, has a very different goal in life, and that is to feel purpose from day one, which is a lot of pressure. And we can get into that later because it certainly makes it challenging to manage and hire and retain people in this, I guess, millennial generation right now. But at the same time, they're such an inspired and motivated generation to make a difference. And I think that we're seeing that in a lot of service industries, that there's a lot of people either changing career paths to go into a industry of service where they can feel like they are serving others, to have that sense of that gratifying feeling of, having a really profound purpose in life. And often that doesn't bring home a lot to the table as far as financially, which goes back to my original point that it's kind of very different from previous generations. So I think while my educational journey's been long, I think I'm one of just many hundreds of thousands that are in my early 30s who's, had a couple of different career paths and have had a lot of degrees, and I'm in a lot of student debt. But, I think that's kind of where our country's headed in as far as education, especially in healthcare. I think a lot of people are getting back and, leaving one industry to go into healthcare for a number of reasons. And so I'm certainly not unique in my educational path.
Fascinating, Heather. And that's quite an interesting perspective in that. And, with all that you've been through, I'm kind of curious here for, and also as well for our listeners who perhaps aren't really exactly sure, what kind of things are covered in a nursing program specifically. Do you think you could kind of give us just a brief overview of just some of the classes or some of the stuff that you really learned in nursing school, just as so that other healthcare providers can kind of gain a sense of what nurses have been trained in?
Sure. So in nursing school, a lot of the foundations, both in undergrad and graduate level education, has to do with the study of pharmacology and pathophysiology. So while there is a focus on anatomy, there's it was more of a prerequisite, if you will, for my nursing program to have some courses in anatomy. But really, when it came into studying nursing, it was more about studying how the body reacts to disease and the disease processes and the organ functions in each system, and then how the body interacts with the drugs that we give it. So it's kind of a different, I think that's a slightly different approach than you may have in, say, medical school, where there's a lot more of my understanding is there's a lot more of education that, drills down to the bodies and drugs and reactions to each other on like a molecular level and the chemistry that goes into everything. It's not, I would say you can take a chemistry class and probably have a leg up in some way when you're in nursing school, but it's certainly, I feel like it's more of a global picture that we're taught of the human body and its responses to disease and to drugs. And so that's kind of the core when it comes to the sciences. And then when it comes to the nursing courses, it's kind of it's studying the drugs, yes, and the body, yes, but also how to advocate for your patient. So, I think something that's really drilled into every nurse when they graduate from nursing school is that you're the last line of defense and your patient's ultimate advocate. And often they're only advocate in certain parts of nursing where family may not be there or be there yet, and you are that final advocate at the bedside. And so I think that's a belief that is ingrained in all nurses when they leave nursing school. But the foundations are more in there, while there is some into the science and pathophysiology and study of pharmacology, you really graduate with I think a lot of tools in how to care for patients and carry out the plan of care that is set by the healthcare team. And there's a lot of focus on, it's not really the politics of healthcare, but where nursing stands in healthcare and the concept of shared governance, and even a bedside nurse having a voice in the policies that go into patient care. I've been really fortunate to be able to sit on a lot of committees that were interdisciplinary. And I think that the foundation of shared governance that I was taught in nursing school was really valuable. And I think that's something that potentially isn't really taught in every healthcare discipline, but I think nursing schools are doing a really good job of fostering an environment of of promoting evidence-based practice and really ensuring that they're graduating nurses that still need a lot of experience at the bedside, but are at least going to the bedside with a good foundation of understanding the human body and how the body reacts to disease and to drugs, and then how to best advocate for the patients in the healthcare setting.
Yeah, Heather, that's awesome. That's a great perspective on that. I see a lot of parallelisms with nursing and with physical therapy, because same thing, a lot of our experience is we get so much time with our patients that we have, a really good grasp on the patient experience, and what it means to kind of advocate for them and to really meet goals that they want to set, not necessarily, tiny goals like, range of motions and strengths, but like, hey, I really want to be able to pick up my grandchild again. Oh, okay. Well, then let's work toward that, even though that may not be the original task that was handed down, so to speak. And I have to admit, I already kind of know a little bit about the world of nursing and nurse practitioners because my sister-in-law is a nurse and my brother is a nurse practitioner. But for our audience who isn't aware, could you maybe tell us about the process of transitioning from nurse to nurse practitioner and the differing responsibilities of the two titles?
The difference between a nurse and nurse practitioner and the difference in responsibilities. Yeah, I think, the nurse practitioner has, and every state has different laws surrounding the scope of practice for nurse practitioners. But for example, in the state of Tennessee, they just passed legislation that in the state laws, it's the nurse practitioner and physician relationship is described as not one of supervising one over the other. So not one of which historically it was that all nurse practitioners had to have what they called a quote unquote supervising physician. And now it's described as more of a collaborative relationship. So I'm working on getting credentialed right now, and all of these documents and things that I have to have signed and stamped and sealed are all being rewritten to talk about the collaborative relationship. So while there are still some documents that list, who's my supervising physician, when it comes to describing the actual roles in action, it's more of a collaborative relationship. And so in the state of Tennessee and in most states, nurse practitioners can prescribe medications, diagnose, treat, and prescribe. So to the average American who's not in healthcare, if they go to see a nurse practitioner and compare it to a visit with an MD, they're really not going to sense much of a difference. While there's a vast difference in the training and what goes into each role, what is delivered to the patient is very similar and often can't be really differed one from the other. How that differs from a nurse is nurses don't have any prescriptive authority and they don't diagnose. They carry out orders and advocate for patients and assess, and their treatment and assessment of a patient in an ideal world as a nurse practitioner, I rely very heavily on the nurses taking care of a patient to report changes to me, to pick up on things, to assess the patient. And then I can go in and help tie the pieces together and build what they're bringing to me into the plan for the patient. So I would say stepping into this role, the biggest change for me is it's really quite a big step back from the bedside and having a more global view. I think in some of the times where I felt the most on fire as a nurse was in shifts where I had a very sick patient and my day was just consumed with tasks, and checking boxes and doing tests and sending labs and giving medication and titrating medication. And it was all very task-based, but, I was carrying out the orders and the plan and everything that was set by the healthcare team that included nurse practitioners and physicians. So now I'm in that healthcare team and I'm relying on nurses to be motivated and excited about doing tasks and being on fire like I remember being for the patient. It's a very busy job, but I think as a nurse practitioner, you have a much more global picture and view of things, and you really are taking quite a big step back from what was my norm, which was at the bedside with, spending 12 hours straight with a patient and family. It's a very emotionally involved role. And as a nurse practitioner, it's still very involved in, an emotional, but in a very different way. So I hope that's a good description. And I'm coming also from the inpatient side. So in an outpatient world, in the clinic world, the roles of a nurse versus a nurse practitioner could even be more different to someone who works in that environment. But I'm coming from more of a critical care and inpatient standpoint.
Awesome. No, that definitely provided some good insight. And, kind of hearing the difference between, what a nurse does and what a nurse practitioner does, I'm kind of curious, do you think Heather, that you could kind of tell us a little about differences between your nursing program and your nurse practitioner program.
Sure. So when I started the graduate program, I immediately was taking pathophysiology and pharmacology and kind of walked into it with this grand assumption that this would be like just a review course. And it was humbling, to say the least. It was to a whole nother level. I don't really know how I can describe the difference in the graduate studies directly from the nursing program, because it was so long ago that I was in nursing school, but it was certainly more intense. And then moving out of the core curriculum, our coursework there was a lot more focus on writing notes and developing plans of care for patients and working through differential diagnoses. So, and when I say that, I mean, if you're presenting with a cough or if you're presenting with chest pain, there's a long list of what they call differential diagnoses that you have to rule out or rule in. And, because chest pain can be acid reflux, it can also be a heart attack, it can be a number of, and so, having a depth of knowledge of the human body and symptom management and what symptoms mean, I think was a huge part of my program, and being able to develop a plan of care and kind of march through all these different diagnoses so you don't overlook, something that's really right in front of you. So it was a lot more intense than I found nursing school to be. I think I enjoyed the graduate program more than I enjoyed nursing school. Perhaps that's because I felt I knew exactly what I wanted to do coming out of the program, whereas as a new nurse, it's very hard to get your first job as a nurse. So I was nervous that I would even get a job in a hospital. I wasn't sure if I would get what I wanted starting out. So it was just a lot more intense, a lot more at stake, a lot more research driven. There was a lot of research that you had to do in the graduate study, and there's even more research and that level of education when you talk about doctors of nursing practice, DNP programs that are out there now. It doesn't change the scope of practice of a nurse practitioner, but it is considered the terminal degree, and it's more research focused. But I guess that's in a nutshell the difference between the two. More of, I guess, an intensity thing.
Yeah, gotcha. Definitely focusing on, kind of prepping you for that role as kind of being more of the overseer, of kind of the patient's care more so comparatively to just the traditional nursing school. I think that was very interesting, good points. And Heather, from your perspective, what are some of the troubling issues currently facing nursing education, and where do you see the future of nursing education moving towards?
I think that there's a lot of great things in nursing education, and there's a lot of struggle as well. I think that where our healthcare industry is right now, the demand for advanced practice providers like nurse practitioners is going up. So there is greater demand for people to go back to school from the bedside and become nurse practitioners. They're also paid a higher rate. There's a lot of motivations for people to, in order to meet the demand, there's a lot of bridge programs out there, similar to what I did to get my BSN, but there's bridge programs out there now where you can go from having a bachelor's in whatever field and go through a bridge program and graduate actually with a master's degree as a nurse practitioner. The great thing about these programs is that they are graduating hundreds and thousands of nurse practitioners into the healthcare industry and meeting this demand. However, a lot of these programs are not at their core designed, or there's not a lot of built-in time to give you a lot of experience at the bedside. And I think that's creating a bit of a rift in the industry from a nursing perspective, because when I graduated from nursing school, I knew I probably wanted to go back to school and become a nurse practitioner, but the thought of that level of responsibility over someone's life was very alarming. And I just felt like, and I remember when I was interviewing at Vanderbilt for my first job in the surgical ICU, they were asking me what my long-term plan was. And they said, do you plan on going back to school? And I said, maybe, but I feel like I need to be an expert nurse before I can go back to school to become a nurse practitioner. And I think that that's always been a very commonly held belief in the nursing industry, that you become a nurse practitioner when you've reached the level of an expert nurse. But the demand is such that there are more and more of these programs being built and graduating nurse practitioners that actually haven't spent any time at the bedside. So they're certainly equipped with the knowledge base that I got from the program I just completed for my MSN, but they're not coming into the role as a nurse practitioner with a ton of experience at the bedside as a bedside nurse. And I'm concerned about that. I think there's a lot of liability in that. And while I think it's there, we have to, our country and the industry needs to meet that demand, it concerns me that we're graduating a lot of people into the industry that haven't had a lot of experience already in healthcare, and especially not as a nurse. The other thing that concerns me is that as the demand increases and as more people enter the field of nurse practitioners and there are more people to advocate for independent billing and a more solid scope of practice across the country. And listen, I believe we should have it. I think that you're certainly prepared with these educations to have all of that. But there are more and more people coming into the field that probably really could use a couple of years at the bedside before using their NP license. And I know several people who have graduated from these bridge programs and had that realization and spent a couple of years at the bedside before taking their first nurse practitioner job. And so I think that's a great workaround to that. They got the best of both worlds. They got to complete a bridge program, which is expedited, but all the education that you need, and also spending time at the bedside prior to advancing to the next level. So I guess that's one thing that concerns me, or a lot, is what we're doing to meet that demand for nurse practitioners. In the world of nursing, some of the challenges I think we're facing right now is that this new wave of nurses coming into the field that are of this latest generation, they have this incredible desire to feel purpose and to have an effect and to have a real effect in the world. And they've also grown up in a culture where they have immediate gratification. And so I think there is a lack of patience for that prize of feeling purpose. I mean, I just think that as a brand new nurse, it's a really hard job. I mean, you go from, I feel like I had a little more worldly experience when I graduated from my nursing program because I had already had a previous career. But there's 21, 22-year-olds that are graduating from college and may have not had a lot of jobs leading up, through college, and their first job is taking care of people's lives. And it's a huge responsibility. And I think that, there's been a couple decades of young men and women that went to, their middle schools and high schools, and they were getting, or elementary school maybe, and were getting medals for showing up to a race, prior to running it. And so it's this world of, everybody gets a slap on the back and a thank you for showing up. And that's just not ever, I feel like that's just not been the culture in healthcare. It's too tough for that, and rightfully so. It's very high risk, and I think that that's a struggle that I had managing and leading people, is trying to be really engaged and encouraging and lift people and help them feel more motivated and give them encouragement, while also saying, I'm not going to give you a gold star for showing up on time. And if you think that's what you should get, I don't know, that I struggle with that. I really struggle with that as a leader. I just can't wrap my head around that. And I think as a result of this sense of need for immediate gratification in a lot of people that are entering healthcare right now as workers, is there's just a really high turnover. So they spend less and less time at the bedside doing the really tough work, the thankless work. I mean, it's really rough. We're all a little crazy to want to do it. I mean, there is this incredible sense of making a difference, but not without the days where someone's been rude and called you names, and you've got horrible body fluids on your clothing. I mean, it's a really tough job. We're all a little bit crazy, but I think people are coming into the industry with a shorter fuse, I guess, is in so many ways. And so we have a more rapid turnover. There's very few incentives in the world of nursing to stay at the bedside for a long time. There's really a pay ceiling. You tend to cap out around the country at different rates. In the state of Tennessee, we don't have income tax. And so it's one of the lower, on the actual dollar amount on the scale, we're paid a lot less in the state of Tennessee as nurses and healthcare workers. We also don't have state income tax. So it really comes out in the wash. But I don't know what the national average is right now for nursing, but if it's say $25 an hour, you can start as a nurse in the state of Tennessee at like roughly $20 an hour and put in 15, 20 years, and you're going to cap out at about $35 an hour. So that is it is a hard job to stay in for that kind of cap. So there's little incentive to stay at the bedside and be just a wealth of information and so resourceful to the younger generation of nurses. And then the younger generation of nurses, I think, are coming in with a shorter fuse. So they're staying at the bedside for less time before pursuing graduate level education. And so I feel like we're arriving at kind of the same conclusion that I think a lot of people are moving on in their careers as nurses and nurse practitioners with less and less bedside expertise, and that worries me.
Yeah, I think you hit a great point there, Heather. The participation trophy never really helped anyone, and with anything that you do, I think we're realizing, and I hope, I know it's not just the field of physical therapy. I'm sure you guys are seeing it as well, but there is something to be said, regardless of your degree, about clinical experience and just the years put in at the bedside, like you talk about, and just literally getting your hands dirty for several years and seeing several patients, several hours of just, putting in the hard work over a long period of time. It really does make a difference in the clinician, I think, in the end.
Absolutely.
Heather, I want to kind of pivot a little bit here and go a different direction, but one of the reasons we were so excited to have you on the show tonight is I followed you on some of the social media outlets, and it's amazing to see some of the many achievements that you've accomplished in the world of healthcare, but you're also out and about and just loving life and having a great time. Could you tell us a little bit about the buzzword work-life balance and how you seem to navigate that so well? Because I think it's pretty universal that healthcare workers can and do experience burnout if they're not careful. You seem to have a pretty good grasp on work-life balance, so we'd love to hear your take on that.
Sure. I think it is a really valuable thing. I'm really blessed that my husband is super supportive and he's not in the healthcare industry. So there's certainly been shifts that I've come home and I am just battle weary. And, it's hard for me to communicate with him after some of these shifts. But I actually think that being with someone who's in a whole different industry really helps to do a little bit of healthy compartmentalization. I think it helps me to be able to keep my work life at work and my home life at home. I think when it came to going back to school, for instance, I just knew it's like I'm in my mid-30s. I don't have I don't think in college I ever pulled an all-nighter to study. The concept, I don't know what it's like to not sleep for a couple hours. I don't know how people do it. I'm delirious when I go without that much sleep. But I feel like when I went back to school for my MSN, I'm in my mid-30s and I'm thinking I can probably study for an hour every day if I get up an hour earlier, but I'm not going to be able to pull all-nighters. And if that's not enough, then I may not make it through this program. So I think I set some boundaries for myself. I just tried not to kill myself with all of the work and just doing too much. That being said, I think I had to just also prioritize time that I would spend away from work and from school. And that was really helpful in the end, I think. So, I think the main keys are having people in your life that aren't in the same industry as you, so you can really separate yourself. I think it's also important to have people that you're close to that are in the same industry so that you can vent. There's certain things about work that I don't want to talk about at work, but I probably need to get off my chest. So having people that you can speak to is really important. And I think making time for your own, mental health, whether that, exercise or hobbies, I just think all of that's really important. I was really never, when I was maybe in middle school, I was a runner, but so probably the second year I was at Vanderbilt in the ICU, I just started running. And I think it became therapy for me in a way. I get I get a lot of thinking done when I'm running, and I can replay a lot of scenarios when I'm running. And I think that's something that happens to people who work, especially maybe in critical care. At least it happens maybe more frequently when you're in critical care, that you are in these very intense situations, and then you come out of them and they play like on a loop in your head for days, and you just dissect every action, every word spoken, everything you did. And it's kind of a way of reflecting and growing and learning, but you can really get lost in your head when you work in such a high stakes environment. And so I think finding an outlet for your energy and, for your thinking is really, really important. I certainly didn't go into grad school thinking I had some master plan for how I wasn't going to lose my mind, but I survived and I didn't lose my mind, and I stayed working full time. But I had a really supportive family, really supportive friends at work and leaders at work and peers that made it all a lot more doable. But you have to just prioritize time and try not to, you can't teach an old dog new tricks. There's nothing I'm going to do differently in my 30s about how I study for something that I did when I was in my 20s. You just hit the books and you try to do it the best you can. But I think at this point, I had learned from previous experiences in school and just tried not to overdo it. And it worked out pretty well.
Yeah, Heather, I think you make a lot of great points in there. And I think a lot of it also comes down to as well, kind of knowing thyself, because for example, like I'm a little bit different than you in terms of I could not wake up early to do studying. I'm the opposite. I'm the kind of person that would do it late at night and then sleep in, that's just me. And that's fine. There's variance between everyone that. And I think that's something to be respected. And I think what you said too before about, when a clinical situation has occurred and you're replaying it constantly in your head. I mean, with me being 2 years out as a therapist, I've gone through that quite frequently as well, especially my first year, and I still do to this day. And I think for me, the biggest struggle that I've had to face is not to internalize it and not to think that, I look back, I'm like, what? I should have done this. I should have said this. I should have perhaps modified and done this, and not let it really get to me, because I would used to think about it all the time, like, Brandon, you messed up. You should have done this. You should have done this. It would have been way more effective, blah, blah, blah. But instead, I'm like, I got to reflect and not dwell on it and move on, because it's just pulling me down even worse, and it's just not getting me anywhere.
Yeah, absolutely. You have to stay out of your head. But there's lessons that can be learned and you can grow from thinking, but certainly it's easy to get lost. And, that's, I think, where a lot of burnout starts. And I think there's a lot of symptoms of burnout that we don't realize we have. I think it's really important to stay educated on recognizing signs of burnout. There's an amazing nurse that I work with who I was lucky enough to be her leader in the last year and a half. And I've always looked up to her. And and she and I just were having like an evaluation at the end of the year last year. And she just expressed that she was feeling really burned out. Or actually, she didn't express she was feeling burned out. She said that she had felt like it was hard for her to get time off to attend continuing education. So we made a plan to help her to get the time off she needed to do that. And the first course she took was on healthcare worker burnout. And she came out of that course just on fire. And she just was like, I had no idea how burned out I was. The symptoms are it's like learning about any very difficult to understand disease is, you sit in a classroom and you're taught by the expert and you realize, oh my God, I think it's kind of a joke in nursing school that you begin to diagnose yourself with everything you're learning about at the time. But in this case, I think it is really one of those processes that once you learn about really what some of the main signs and symptoms of burnout are, you start to realize, holy cow, I've been there, or I am there, or I know several people that are there. And it's certainly important to be familiar with what those signs and symptoms are for both yourself and for your peers.
Yeah, no, absolutely. I think that's a very important topic. And, kind of switching gears here, Heather, and, with over the course of, going through your programs, through the nursing program, through the nurse practitioner program, what are some of the traits that you saw that made really great educators in the field of nursing?
Tips that make great educators. I think listening. I think that's probably I think being an active listener is one of the greatest tools that can bridge two different generations of nurses in an instant. I think that probably through all of time, I think one thing that can be maybe said to be consistent from one generation to the next is the desire to be heard. And so I think being an active listener and being able to drop what you're doing, no matter how important you think it is, if someone comes to you and wants to talk about something, being an active listener is so important. And I think it's something I struggle. I think that's probably one thing I struggled with the most when I was in school in the last year and a half, is that I had my days and everything planned out so well, and I would be juggling so many things at once that it became really hard for me to drop what I was doing to have an unplanned conversation with someone about something maybe that didn't seem to be a big deal and wasn't an emergency, but it means so much to people to feel heard, and like what they are coming to you about can get your full attention. So I think that's easily my biggest tip. I think other tips for great educators are fostering engagement. So I think something that's missing, and I don't think this is just unique to nursing or even healthcare, but I think when we kind of when we trend performance or do root cause analysis on an event, for instance, and we come across something and it's just like, and as a group of leaders, we're like, we've educated on this, we've done that. What else can we do? Why do we keep forgetting this? Or why do we keep messing this step up? And it could be something as simple as the timing of a lab draw, something that doesn't result in anything of significance to the patient, but it's like a quality indicator. You want to do things within a certain time frame in a certain way. And, why are we struggling with that? And we kind of arrive at this conclusion sometimes where it's not about education anymore. This is about staff engagement. This is about people maybe being burned out. And so I think as any educator, if they can learn how to foster and support engagement from their staff, it makes such a difference, because suddenly all the knowledge you've equipped someone with will click. Whereas if someone becomes really disengaged from their job, those people worry me, because no matter how much education you put out there, no matter how much support you offer, if it's not going to re-engage them, you're kind of stuck up a creek. And that's a very difficult position to be in, I think, as an educator and as a leader, when you're recognizing disengagement. And so I don't think I have a really ultimate tip on how to engage people. I think maybe step one is being a really good listener. But yeah, engagement and listening for sure.
I think that's a great way to kind of bring it back full circle, because we see a lot of that in the physical therapy field, especially with our evaluations. We're finding now more and more, I think, that it's so important to just ask your question and then shut up and just listen. Listen to the patient tell the story. Listen to the patient explain to you, and you'll get your answers. If you just sit there and then listen, and then, like you said, with engagement, I think sometimes, after they've run out of everything they need to say, maybe just a little prompt in order to engage them again, and they'll start talking right away again. So that's just for the patient side, but I think, that can be converted over to the student side as well.
Oh, absolutely. I think that a lot of that does apply both in relations with peers and with people you could be leading at any time, and also with patients. Absolutely. I think that customer service is a huge part of the healthcare industry now, and I don't think that people come prepared for it. Really think that it's a hard thing to teach. And I think for me, I learned customer service as a waitress for just years in undergrad, and when I think that's kind of what built my baseline. And in the world of restaurants, the customer's always right. That's really in the world of most retail, I think. And having a good understanding of customer service is so important. And I think that the key number one is listening. I think that, when people talk about statistics in healthcare and what are the trends in why do people sue? Why do people decide to file suits against hospitals or healthcare providers? And it's not actually, when the research has been done, it's not the gravity of an error or perceived error. It's often that they don't feel they were communicated with, or they feel like they weren't kept in on, it all really boils down to communication. And I think that really says a lot. If we walk into a patient room and start talking to them about all the things that are going wrong, and you don't pick up on the fact that the wife is hard of hearing, and you just told, I literally had this exact situation happen to me when I was in school. I was with the palliative care team, which was probably one of the most amazing rotations I had the opportunity to do. And we went to see a woman who had terminal cancer diagnosis and had kind of failed treatment, and her mom was hard of hearing. And we went in to talk to them about palliative care and pursuing quality of life at that point. And when we asked the mom what was going on, she just said, well, she's doing really well in treatment, and she's been doing everything right, and we think the doctors are really pleased. And we stepped out of the room and talked to the resident and just said, something's missing. What exactly did you tell them earlier? And he walked us through all of it, and we just said, I don't know how this isn't coming across. And we went back into the room and realized very quickly that the mom is extremely hard of hearing, and she wasn't hearing anything he was saying, but she was so intimidated by his body language and the white coat that she didn't ask any questions. And the patient was not in a place of understanding what was really going on herself. And so it was really powerful to me to learn from a team that's encountered that a lot by nature of what they provide and coming into these situations where there's maybe perceived denial or a lack of understanding about what's going on. And unfortunately, they've had a lot of experience in realizing that a lot of times this is just that we're not communicating well. We could do just such a better job of communicating with people. And in those situations are very different from ones that might lead to like a lawsuit. But I always find that interesting that the number one reason for healthcare litigation is really communication.
Yeah, I spent my summers caddying on a golf course at a country club. So that's where I learned a lot of my communication skills and customer service skills, and it's really paid off in the healthcare field, to be honest with you. All right, Heather, time for the big wrap-up. We like to ask all of our guests this final question. If you could change one aspect of higher education, whether it be nursing school or nurse practitioner or otherwise, what aspect would you change, and how would you recommend changing it?
I think that I feel really good about the general nursing education, and in healthcare, nurses that graduate either with an associate's degree in nursing or bachelor's degree. I think that has long been the most difficult undergraduate degree to obtain, and I believe it should be. So I think that we're doing something right there. I think that we as a country need to we're walking these two roads of one being that we are advancing the scope of practice of nurse practitioners and creating more collaboration with physicians. And it's just an incredible thing to be a part of. But we're also graduating people from master's programs that have very little experience at the bedside. And even if they still can translate all of their education into all the skill that they need to start that job, it's hard to argue that they have the level of customer service experience as a bedside nurse. If you didn't already have customer service experience prior to becoming a bedside nurse, you certainly get it pretty fast. And so I think that while we need to certainly advocate for independent billing and all of these things within our scope, and as nurse practitioners, and we want to meet the demand of the industry for more providers, we also need to really be careful with the path to graduating from these programs that are out there, because I just think that either having more stringent requirements for the previous level of experience that applicants have to have prior to getting into graduate nursing programs, I think that would be one way that you could start. And by all means, most programs do have minimum requirements, but I think it gets really tricky with these bridge programs. And I think there is always going to be a percentage of graduates that realize I really need some bedside experience before I should, take my first nurse practitioner job, I think that would be a really helpful thing to build into those programs, is that you might be able to graduate with your MSN after, 20 months or 22 months. But as a part of the program, you're committed to working 2 years at the bedside or something to help build those foundations that you can't get in a classroom. And even with all of the clinical rotations you might have when you're in undergrad, it is not the same. So, I think that could be one place to start, is just to stay stringent. Our institutions need to stay stringent about requirements that they have on applicants. And also, I think in the bridge programs especially, having some way to ensure that they are going to release nurse practitioners into the workforce that do have some bedside experience is also really, really crucial. And I don't know all the right steps to take, but I certainly would like to see that happen as these programs grow and continue to try to expand to answer to
Awesome. So kind of like trying to get some sort of standardization of experience and care, for that matter, kind of for, nurses that are trying to go more into the nurse practitioner role. I think that's a good point. And I think that's something that, PT has been working on as well, especially from the clinical education standpoint. And, that's what one thing that they're really trying to work on here. So I think that's a good takeaway and such, Heather. And thank you so much, Heather, for your time and for coming on the podcast with us tonight. As I've definitely learned a lot and some new stuff regarding nursing and nurse practitioners that I really didn't know about before. And, of course, we wish you the best with your new position, and that's great. Would you mind telling our audience a little bit about where they can find you online and on social media?
Sure. So I have an Instagram account. I think it's Heather Hart or Heather Ann Hart, maybe. And then I do have a Facebook page. I'm trying to revamp my Twitter thing. I was one of the early adopters to Twitter. I think my Twitter handle is my full name, which I think is virtually impossible to do now because there's so many Twitter users. But I think it's at Heather McMurray, which was my maiden name. But especially through Vanderbilt, we do a lot of outreach through the trauma center, and there's a lot of communications and networking that happen through Twitter now, at least at Vanderbilt. So I'm thinking I need to kind of re-up my investment into Twitter. So I might be on there more these days, especially when it comes to talking about health. That might be how I'll compartmentalize moving forward. I'll keep my Facebook and Instagram more about, bathtubs and gardening, and keep my Twitter feed more about the woes of the healthcare industry.
All right. Yeah. Well, thank you so much for coming on, Heather. And we will put all the links and such to everything as well in our show notes as well. And thank you so much for your time and for coming on.
Yeah, thanks so much.
Thank you so much. Pleasure is mine too.
Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.